ma'am.
Okay. Proceed. Can you tell me some of the causes of loss of appetite?
Ma'am, peptic ulcer or because of acute infections, ma'am, or
Any other ailments?
ma'am, any
Means-
malignancy, ma'am, in malignancy
malignancy.
also.
Yes, you
There
are right.
in TB also, ma'am, the person loses his appetite, ma'am.
Okay.
And in
Okay.
any any diseases bowel disorders, ma'am, like intersusception or appendicitis or volvulus, ma'am, any congenital
Interception,
obstruction.
appendicitis, these are all acute intestinal conditions where they
Yes,
may
ma'am.
be presenting to us with some pain, abdomen and vomiting or
Yes.
current jelly stools and all, but not
Yes.
loss of appetite. But as you told earlier, those were the right indications or the causes for loss of appetite. Okay.
Okay, ma'am.
So don't get into panic. Huh? You must be calm, think over. It happens because video presentations are for the first time, but this will be the same for you in exam also. So you
Okay,
should
ma'am.
not get panicked when some question is asked. Be
Okay.
very focused, calm, think
Yes,
over
ma'am.
and tell. Nothing hurry to tell. huh? Maybe
Okay,
now
ma'am.
we have time constraint. There also you should be very much composed. These are the questions commonly asked. When you
Okay.
tell there is less intake of food, so naturally we consider for the loss of appetite, isn't it? Is there
Okay.
any loss of appetite? Why he is not taking the adequate calorie and what are the causes of that? Okay.
Okay, ma'am. Ma'am, moving on to the personal history.
Just a minute. There is deficit of calorie of 820 and 15.5 gram of protein, isn't it?
Yes, ma'am. Yes, ma'am.
So what you should think of to add to the calorie so that the child will take more and fulfill this? What
Ma'am,
advice?
ma'am, we tell the patient to uh, um, have a more, like the person is having mixed diet, ma'am. So we tell the patient to increase consume more non-vegetarian, and along with that ragi consumption of ragi is very nice substitute, ma'am. Along with that, ma'am, dal we can tell the patient because there is a loss of lot of proteins, ma'am.
Mhm.
And along with that, the
You are
normal,
taking mixed diet, na? Mixed diet, which is the richest protein substitute for all these?
ma'am, soya, ma'am,
Which are the reference proteins?
ma'am, egg,
Egg and milk. Okay,
milk
good.
proteins, ma'am.
So though their digestibility and absorption is very high. So
Yes,
ideally we can add those two things to this, which will give more calorie with
yes,
some
ma'am.
of the other things like ghee and oil, which
Oil.
will help improve very fast without increasing the quantity of the food. Quality is improved, but quantity will be remaining little lesser side. Okay, go ahead.
Ma'am, shall I continue?
Yes, next class.
Moving on to the personal history, diet is mixed, appetite is normal, sleep adequate and sound sleep, bowel and bladder is normal and regular, and it is not associated with any habits.
Okay.
Moving on to the socio-economic status, head of the family is father, a farmer as profession. There are three family members, belong to a class 3 of modified BG Prasad classification, lives in Pakka house, drinks filtered water and use toilet. There is no exposure of mosquito, ticks, mites and flies. There is no exposure of cattle and pet animals. There is no harmful child rearing practices.
Okay. Okay, that's okay.
In my summary, here is a 13-year-old male child who is born to a second degree consanguineous marriage belonging to upper lower socio-economic status who consume a diet of 2% deficient in calories and 24% deficient in protein, who is immunized up to date with a normal developmental milestone and with past history of known case of an hematological disorder, came with a complaint of EC fatigability since 6 days and a progressive pallor since 5 days.
Okay. With this history, you have come to the conclusion that it must be some hematological disorder. That
Yes,
is
ma'am.
good. And now also he has come for the blood transfusion only.
Yes, ma'am.
They are admitted for that only.
Yes, ma'am.
In your history itself, you can tell easy fatigability and pallor, and they have come for their scheduled dose of blood transfusion, whatever. Because
Yes,
we
ma'am.
will have counseled them that you should come every third week, fourth week, whatever they are coming. So that
Yes,
can be added to the history. Okay.
yes, ma'am. Shall I
You can,
continue?
yes, you can continue.
Moving on to the general physical examination, here is a
Just
30.
1 minute, Santosh.
Yes,
Here
ma'am.
you can add one more history, that is the treatment history in detail, which you have told a very little thing. And a heading you can add like treatment history. That will give, you told about that, but it could come as a separate one, which will
Okay.
give us more clue. You told some amount of transfusions were given and iron was also given.
Yes, ma'am.
Anything in between mishaps or this time any treatment was given, since 3 days baby is here, na?
Yes, sir.
How many
Yes,
days
ma'am.
the baby is in the hospital now after your admission?
Ma'am, child came for the blood transfusion, and just 1 day, ma'am, that person will be.
Okay. Okay. So add the treatment history. Put it as treatment history. Okay.
Okay,
Hmm.
ma'am.
Proceed. You can proceed.
Yes, ma'am. In general physical examination, here is a 13-year-old male child, conscious and cooperative, and well oriented to time, place, and person. In vitals, pulse is 98 beats per minute, measured in the right radial artery, regular in rhythm, normal in volume and characters, no radio-radial delay, and no radio-femoral delay. Respiratory rate is 22 breaths per minute, abdominothoracic type. BP is 106 by 82 millimeter of mercury, measured in right brachial artery in sitting position. Temperature is 98 degree Fahrenheit, measured in axilla. Pallor is present, but icterus cyanosis, generalized lymphadenopathy, and edema is absent.
Okay. So regarding pallor, can you add little more about it? Whether it is a pallor is severe,
Ma'am, the pallor is mild, ma'am. Mild to moderate, ma'am.
moderate, not severe
Yes,
pallor. So
yes,
what
ma'am.
are the traits you will look for pallor?
Ma'am, we look for lower palpebral conjunctiva as well as dorsum of the tongue, ma'am, or the palate, ma'am, or palm and sole, ma'am, or nail bed, ma'am.
Nail bed. Okay.
Yes, ma'am.
In this
So,
find, no icterus was there?
no, ma'am.
No icterus. Do you
No.
usually find this icterus according to your history?
Ma'am, if the blood transfusion is well managed, ma'am, the icterus is not there, ma'am. But if it is irregular blood transfusion, or if the person is having any blood transfusion associated infection, ma'am, then icterus will be present, ma'am.
Maybe there. Okay. But
Yes,
as per your history, he is taking every third month one transfusion, isn't it?
yes, ma'am.
3 months he is coming once. Okay. Okay.
Ma'am, shall I continue?
Yes, you can continue.
Okay, ma'am.
Continue.
Moving to the head to toe examination, hair is normal, frontal and parietal bossing is present, malar prominence is present, in eyes pallor is present, flat nasal bridge is there, uh, teeth is normal, oral cavity is normal, nails are normal, skin is pallor, and no hyperpigmentation or petechia is seen, chest, spine, and back is normal, and genitalia is normal.
1 minute.
Yes, ma'am.
In the oral cavity, you can tell it as not normal. Pallor is there.
Yes, ma'am.
Is it there or no?
Yes, ma'am. It is there, ma'am.
Okay, so that disparity should not come. Eyes is showing pallor. Definitely oral cavity, oral mucosa and the tongue should show pallor until unless they are having anything else like where it
Okay.
could be red. When it will be red?
Ma'am, in iron deficiency anemia, glossitis is present, ma'am.
Glossitis, whatever may be the cause, glossitis and stomatitis, if it is there, they may not be having the pallor. Otherwise,
Okay.
it will be there. Okay.
Yes, ma'am. Yes,
Then,
ma'am.
where do you get frontal bossing?
Ma'am, in thalassemia major, ma'am.
Why? Why do they have?
Ma'am, because extramedullary hematopoiesis is there, ma'am, where the medulla expand to the cortex.
Okay. Can you mention some of the causes of frontal bossing?
Ma'am, if it is abnormal fusion of the bones, ma'am, and if it is delayed uh, growth, ma'am, and along with that,
He is having nutritional deficiency, as per you told. So,
yes,
any
ma'am,
nutritional causes for any nutritional factors causing frontal bossing?
rickets, ma'am.
That is rickets.
Yes,
That is the commonest thing.
yes,
That could be a associated feature also along with this extramedullary hematopoiesis. Okay,
yes, yes, ma'am.
you can go ahead. Yes.
Moving on to the anthropometry, uh, expected weight of the child is 43 kg, but it
And,
is
okay, okay, continue.
but it is 40 kg, whereas height of the child is supposed to be 155 centimeter, but it is 143 centimeter. Upper segment and lower segment is 1:1. Head circumference is 58 centimeter, and mid-arm circumference is supposed to be more than 13.5 centimeter, whereas it is 12 centimeter, ma'am.
Okay. So, what is the percentile difference was?
Ma'am, the weight, height, and head circumferences, ma'am, between third and 15th percentile, ma'am, which
It
is
is a
indicative of malnutrition, ma'am. Shunting as well as malnutrition, ma'am.
malnutrition. What malnutrition? You have written it as moderate malnutrition.
Malnutrition, yes, ma'am.
According to classification,
Ma'am, if it is more than 13.5 centimeter, it's normal, ma'am. But if it is between 13.5 centimeter to 12.5 centimeter is mild. Between 12.5 to 11.5, it's moderate. And if it is less than 11.5, ma'am, it's severe.
yes. Santosh, do
Yes,
you
ma'am.
take mid-arm circumference at 14 years or 13 years age? Mid-arm circumference is taken from what age to what age?
Ma'am, till 10, more than 11 years, ma'am.
No, 1 to 5 years only. Ah,
Okay,
so
ma'am.
make it a note. It should not exceed 1 to 5 years. After 5 years, we are not going to take, and before 1 year, we are not going to take. What may
Okay,
be
ma'am.
the reason we are not taking?
Sorry, ma'am. Sorry, ma'am.
Why do you not take before 1 and after 5?
Because, ma'am, the child is still in the developing phase, ma'am.
No, all
Before
the
1 year.
is developing only. Huh? It is a growing child always, even in infancy also, because subcutaneous fat is more there. It will not give us the proper nutritional status. And
Okay.
after 5 years, it starts using the hand, where muscular hypertrophy is there, and the nutritional status won't be known properly. So the
Okay.
ideal way of measuring the nutritional status from 1 to 5 years is mid-arm circumference. Otherwise, we'll be taking the other things.
Okay,
Okay.
ma'am. Okay, ma'am.
It is mentioned in your book. You can check also. Okay.
Okay. Okay,
Hmm.
ma'am.
Yeah. And in here, that mid-arm circumference is ruled out. The percentile chart is showing weight and height are both between 30th and 50th percentile.
Yes, ma'am.
So tell it is malnourished or not. And according to which classification you should know.
Ma'am, if it is, ma'am, in height, if it is more than 80, it's normal, ma'am. If it is between 80 to 70, it's grade 1 malnutrition. If it is between 70 to 60, it is grade 2. Whereas in between 60 to 50, it's grade 3. And if it is less than 50, ma'am, it is severely malnourished, ma'am.
So here, what will be your interpretation? So what it is now? Third to 50th percentile, you are telling.
Ma'am,
Is it
grade 2, ma'am.
grade 2?
Yes,
According to
ma'am.
which classification this is?
Ma'am, IAP.
IAP. Okay. So, man, You should know at least one or two classifications and
Yes,
tell
ma'am.
that. You need not get confused. And another one will be the severe form where you are going to add with edema and with wasting if it is there, for which
Yes, ma'am.
marasmus for sure. Okay.
Yes,
So
ma'am.
those
Yes, ma'am.
things you have to be perfect. Hmm?
Yes, ma'am. Okay.
Especially in the geometry. Next.
Okay, ma'am. Moving on to the systemic examination, I would like to
Ah,
go with abdomen examination.
one more correction. One more correction. You
Yes.
never forget to tell about something in general physical examination in this child, especially. What is that you have forgotten? Anything? Your friends did not help you, I think. Huh? Friends have helped you or not? Santosh?
Yes,
Don't
ma'am.
get you be free, feel free, nothing. You did your friends respond help you?
No,
No.
ma'am. No,
Why you
ma'am.
did not take help? Huh? Okay, okay, not a issue. See, you must never forget to take sexual maturity rating for a 13-year-old child.
Yes,
Hmm?
ma'am. Yes,
It's
ma'am.
very, very important. And can you recollect and tell me what is the stage of SMR in this child and what are the points you are going to take?
Ma'am, in grade one, ma'am,
Hmm.
there is a
No, 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 no. I don't want the theory part here. The child was with you in front of you. Just recollect what points you will see and which stage it was there. This child was he
uh,
in a pubertal stage and what growth you have seen or you have not examined only.
uh, ma'am, axillary hairs, ma'am, and pubic hair will see, ma'am.
You will see. Have you seen?
No, ma'am, I didn't, ma'am.
Okay, you were doing the auxiliary temperature you were seeing. That time you could have seen for that, isn't it?
Yes,
So that
ma'am.
would have told us whether he is attaining the maturity or not.
Yes,
Okay,
ma'am.
that is
Yes,
very
ma'am.
important. Huh?
Yes, ma'am.
In all the views, we should never forget to take the
SMR, ma'am.
SMR.
Sexual
Huh?
activity.
Why in this case it is important? If he has
Because,
delayed puberty,
ma'am, because of the child is undergoing the blood transfusion. So if the blood transfusion is not proper, ma'am, the puberty may get delay, and as well as iron load is also there, ma'am. So it may can cause, ma'am,
what it can cause?
ma'am, delay in the puberty and delay in the development of secondary sexual characters, ma'am.
One is generalized failure to thrive because of the decreased intake of food and chronic anemia, which may not be corrected
Yes, ma'am.
properly. And another one entity is there. What can happen in these children? What is that? Any endocrinopathies? Huh?
Yes, ma'am. Endocrinopathy like hypopituitary hypogonadism, ma'am.
So those things can happen. All the thing you go through the things again. Huh?
Okay,
All of
okay, ma'am.
you doing it. That is very common. You should never do a or forget to do the SMR and
Yes, ma'am.
tell about the maturity rating or whether there is a delayed puberty. We were not label it a delayed puberty. At least you should have some of the pubertal signs started now by now. Huh?
Okay, okay, ma'am.
Pulse should have begun here. Okay.
Okay, ma'am.
Okay. Continue. Continue.
Moving on to the head to toe examination.
Mhm. Okay. Head to toe examination. Yes.
Ma'am. In systemic examination, I would like to go with the per abdomen examination. In that, starting with the inspection, abdomen is distended, umbilicus is displaced downward, skin over abdomen is normal, corresponding quadrants move equally with respiration. There is no dilated veins, there is no scars and sinuses seen, no visible pulsation and peristalsis. Hernial orifices are intact, and genitalia is normal, ma'am.
Okay. In
Ma'am, shall
general
I?
physical, yeah. Just a minute. I'm losing the connection. I think Santosh, 1 minute, I would like to introduce you to Dr. Ravikant is here.
Yes, ma'am.
Yeah, sir, you're feel free to just ask few of the question or you can interact with the student. She is Santosh Sharma.
Okay.
Very well.
Better thing.
She has
Good
presented the
evening,
history, sir. You had the history and even the general physical examination she has done just now.
Okay.
And Dr. Rahul is here.
Yes, madam.
Sir, feel free to interact with the student and give some inputs according to you because she has completed the up to the general physical examination. Anything else you would like to add, sir?
Yeah, sure, madam. I will add, ma'am.
You will add it. So, Santosh
yes, ma'am.
and all the participants, these two are my colleagues from BRIMS. Dr. Ravikant is associate professor and Dr. Rahul is assistant professor in our BRIMS Bidar. Okay.
Good evening, sir.
Good evening. Good
Oh,
evening.
you can start. Feel free, Santosh. Don't be under pressure. Okay.
Okay, ma'am.
Okay, you can start with the general physical examination so that sir will go through once to that.
Okay, ma'am.
Quickly, sir, you had did you hear, sir, general physical examination?
No.
Okay, that is a long thing, sir. Only pallor ittu
Positive
there was
finding, can tell.
and failure to thrive little and SMR she had forgotten. I told her if you would
Okay.
like to anything about if SMR is delayed, please feel free, sir.
Okay. Right. So positive findings are only anemia, pallor, and
Yes, sir.
anything else on face? Hello.
Yes, sir.
Anything else on general physical examination on face?
No, sir. The person is having only pallor, sir.
Pallor.
Tyler, and he has told that there is frontal and parietal bossing, sir.
Bossing, sir.
Okay. Right. So systemic we can. Right.
You can start with systemic. Okay.
So I will add one question. You should know what is a thalassemic phasis. Okay, that is
Yes.
very common. No?
Okay,
So
sir.
some characteristic features will be there. The
Yes, sir.
child will be having this frontal bossing,
Yes, sir.
and there will be a malocclusion of the teeth. So
Yes, sir.
gum hypertrophy will be there.
Yes, sir.
So extramedullary erythropoiesis will be happening all the skull bones. Okay, so
Yes, sir.
only the skull will be there, and the other maxillary bones also they will have extramedullary erythropoiesis. So
Yes.
there will be malocclusion of the teeth, frontal bossing, and because of the ongoing hemolysis, there will be some yellowish tinge of the face, and sometimes there will be mild lemon yellow jaundice will be there,
Yes,
and
sir.
there will be depression of the nasal bridge. So all
Yes.
these features will constitute thalassemia phases or thalassemic phases or
Okay, sir.
Chipman phases. Okay,
Okay,
so
sir.
it will be very classical in thalassemia major patient. Okay, so that
Okay, sir.
also you can, if you are able to make out in the patient, that also you can mention in the your examination. Okay,
Okay, sir.
yeah.
Okay, Santosh, you can continue with the systemic examination.
Okay, ma'am. In inspection, abdomen is distended, umbilicus is displaced downward, skin over abdomen is normal, corresponding quadrant move equally with respiration. There is no dilated veins, no scars and sinuses, no visible pulsations and peristalsis. Hernial orifices are intact and genitalia is normal, ma'am.
Okay. Abdomen distended, it is uniformly distended or upper abdomen or lower abdomen, anything like that?
Upper, sir, right, left hypochondrial region, sir. It's upper abdomen is distended, sir, not
Ah,
generalized.
ah. If it is there, you can tell it like that.
Okay, sir.
We have idea that upper abdomen distended means we can think something else. If it is lower abdomen, we can think something else like that.
Okay, sir. Shall I move to the next slide, sir?
Yeah.
Moving on to the palpation. There is no local rise of temperature, no tenderness. On deep palpation, there is a mass in a right hypochondrial which moves with respiration and it is firm in consistency. Smooth surface, sharp border, 3 centimeter below right costal margins, suggestive of enlarged liver. A mass in left hypochondrium moves with respiration, non-tender, firm in consistency, smooth surface, sharp border of 8 centimeters below costal margin, suggestive of enlarged spleen, ma'am.
Okay. So both are enlarged as per you. The spleen and liver both are enlarged.
Yes,
More
ma'am.
of splenomegaly.
Yes,
How
ma'am.
spleen?
Sorry, ma'am.
Spleen is measuring 8 centimeters.
Yes, ma'am.
So, no any grading for splenomegaly? How the grading is done? Okay, you could go back and read about it. The grading of splenomegaly, one thing, and
Okay.
liver. Where you are measuring the liver, and you told it is enlarged, right, 3 centimeters below the right costal margin, isn't it?
Yes, ma'am. Yes, ma'am.
Is it enlarged liver, or it may be? Is it apparent or true enlargement? I want to know. How will you confirm?
Ma'am, if we tell during percussion, ma'am, we tell the patient to inspire, ma'am.
Mm-hmm.
If it is there, ma'am, it is true. Otherwise, it's
No. You can mention something about what is liver span.
ma'am, the distance between the upper border and lower border, ma'am.
So upper border, where will you measure and how will you measure?
Ma'am, we start percussing mid clavicular line below the second costal margin or below the nipple, and then once we are finding a dull note, we tell the patient to inspire, ma'am, in order to differentiate it whether it is due to uh, pleural effusion or not. If it is dull, ma'am, it suggestive of upper border, ma'am, and by palpatory method we start exam searching for the lower border, ma'am, from right iliac fossa. With each inspiration, we move our finger up and we
Yeah, you
palpate
are
lower border, ma'am.
telling that percussion is the correct method to locate the upper border.
Yes,
Sometimes,
ma'am.
as told in pleural effusion, it may be pushed down.
Yes,
Okay,
ma'am.
so
Yes, ma'am.
that may be not the true enlargement of the liver. That is pushed
Yes.
down liver. So
Yes,
here
ma'am.
is it a true enlargement? Which did you try to see the upper border where it is?
Yes, ma'am. This one is
What?
true
Yes,
enlargement.
true enlargement. That's what span of liver also should be mentioned always. Okay.
Okay,
Don't
ma'am.
forget telling about enlargement of liver span.
Yes,
What
ma'am.
is the how much is the length? Okay.
Okay. Ma'am, I written a liver span in percussion, ma'am.
In percussion, you are written. Good. Okay. Then we'll see in the next slide then.
Okay, ma'am. Ma'am, in percussion, dullness present over the mass in the right and left hypochondrium. Liver span is 14 centimeter and no free fluid, ma'am.
Good. Very good. That is correct.
In auscultation, bowel sounds, ma'am, heard.
Okay.
Moving on to the other system. In CVS, S1 and S2 heard, no murmur is seen, no murmur is heard. In respiratory system, normal vesicular breath sound is heard, no added sound. In central nervous system, higher mental function normal and no sensory and motor deficit, ma'am.
Okay. So what will be your conclusion regarding this systemic examination?
Ma'am, I think it is a case of a chronic hemolytic anemia, probably thalassemia major, ma'am.
Okay. Can you give some differential diagnosis list?
Ma'am, as this child is presented at the time of 6 months, ma'am, so suggesting of thalassemia major, ma'am. Whereas in thalassemia intermedia, the presentation is usually late, ma'am. Uh, whereas mm, in iron deficiency anemia, it is not there, ma'am.
Just give one list. You told one is hemolytic anemia, in that thalassemia major or intermediate.
Yes,
Then
ma'am.
next, the iron deficiency.
Next is, ma'am, it is not sickle cell anemia as well, ma'am, because uh, because, ma'am, there is no history of any bone pain and sickle crisis, ma'am. And usually, the presentation of sickle is not so acute, ma'am, like 6 months.
Mhm.
And no, this is not also hereditary spherocytosis, ma'am, because hereditary spherocytosis is autosomal dominant, ma'am, and both the parents were normal. In hereditary spherocytosis, one of the parent is affected, ma'am. Whereas in it is not Fanconi's anemia as well, ma'am, because there is no bifid thumb and any skeletal deformities or any pigmentation, ma'am.
Phenotypic
Along
feature.
with that, sorry, ma'am.
Phenotypic features of the Fanconi's are not there. Okay.
No, ma'am. And uh,
Where else you can get the similar history where they require repeated transfusions? There is
ma'am, apart from thalassemia major, ma'am, uh, G6PD deficiency also, hereditary spherocytosis, pure red cell aplasia, ma'am, Fanconi's anemia, or um, or aplastic anemia, ma'am,
okay. Okay. With
pyruvate
this,
kinase deficiency, ma'am.
okay. So how are you going to confirm your diagnosis?
Ma'am, confirmatory diagnosis is high performance liquid chromatography, ma'am. Confirmatory test.
Mm-hmm.
Where,
Yes, you are right. Continue.
ma'am, where fetal hemoglobin will be high, ma'am, and HbA2 will be high, but there is a decrease in the adult hemoglobin HbA, ma'am.
In this case, the investigation were done or not?
Yes, ma'am, it was done, ma'am.
So what was it showing?
Ma'am, it was confirmed as a thalassemia major, ma'am.
Major. Usually in thalassemia major, which is affected? What are the chains which are affected?
Ma'am, I didn't get that. Changes.
Which chain is
Types of
affected?
circuit.
Which chain is affected in thalassemia major?
Sir, beta globin chain, sir.
You know any specific thing about that? Which is
Uh,
replaced by what? Which amino acid is replaced by which amino acid?
sir,
You got?
yes, sir. There is a in beta thalassemia, sir. There is a defect in a chromosome 11, sir, where
Uh,
the one of the alleles get affected, sir. So, it is classified accordingly, like thalassemia minor, intermediate, and major. In
hmm,
thalassemia major, both the alleles are affected, sir. It's beta
hmm.
0, beta 0. Whereas in a thalassemia intermedia, it is a beta plus and beta 0. Beta plus indicative that there is a decreased production of a globin chain, whereas in minor, sir, beta by beta 0 indicating that one of the gene is normally functioning, sir. Whereas in sickle cell anemia, sir, it is at the sixth position, glutamic acid is replaced by valine, sir.
In that sickle here in thalassemia.
In thalassemia, sir,
Okay, you can read that one. Second thing is what is peripheral smear picture in thalassemia major? Typical picture of peripheral smear.
Sir, there is microcytic hypochromic anemia, sir. Along with that, we can find out teardrop cell or target cell, sir.
Okay.
And
And
Howell Jolly body usually present, sir.
overall, how it looks like? It goes by one film name. Overall peripheral smear in thalassemia major, how it looks like? So many different cells we will have. The picture is like dirty picture. And in peripheral smear of thalassemia major.
Okay, sir.
What about retic count? What will happen here?
Sir, reticulocytes will be decreased, sir.
No. Here increase.
Mhm.
Hemolytic anemia, retic count.
Yes, sir. Reticulocyte increase. Yes,
In iron deficiency megaloblastic, it is
yes, increase, sir.
nutritional, it is decreased.
No.
Hemolytic anemia
In
is
nutritional, it is decreased. Here in the hemolytic anemia, and it will be increased.
Increased. Okay, sir.
So
you know
major.
any rule of 10 in hereditary spherocytosis.
Sorry, sir.
You know this word, a rule of 10 in hereditary spherocytosis.
Sir, in hereditary spherocytosis, it is microcytic, sir, but um, 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 it is completely central pallor will not be there, sir.
Uh,
It is
it appears like spherocyte.
yes, sir. It appears like spherocyte, sir.
Spherocyte. Madam, anything to be asked?
Yeah, that's it. And spleen is 8 centimeters. That's why I was asking you whether that much enlargement is appropriate, or do you think it is going for any other problem? What is
Yes,
that
ma'am.
hyper?
Ma'am, I think in this child, getting a 8 centimeter enlargement is high, ma'am. That child, because of the history of the child, is not getting a regular blood transfusion. So, as a complication, ma'am, this child is uh, getting hyper splenomegaly, ma'am.
Severe enlargement of spleen that causes hypersplenism.
Yes, yes, sir.
It will consume platelet, it consumes hemoglobin, it consumes
Yes.
leukocyte. So you may get a picture like pancytopenia,
Pancytopenia, yes, sir.
hypersplenism. If that is occurring, then the child should undergo. In that case, the child should undergo what surgery?
Splenectomy, sir.
Splenectomy. Should undergo.
Yes, sir.
So, what is the general treatment guideline here in thalassemia major?
So firstly we go with the regular blood transfusion, sir.
Okay.
Which is leukocyte depleted RBC should be given, sir, every 3 to 4 weeks, sir. Along with that, we go with the chelation therapy as well.
Okay. What
In
is
order
normal RBC life of adult
ma'am, 120 days, sir.
in thalassemia?
Sir, it reduced to 30 to 40 days, sir.
That's why you should transfuse by. Actually, it is not at that low. Yeah, newborn, newborn, how much it is? Lifespan of RBC newborn?
No, sir.
Okay. It is around 90 days.
Okay, sir.
So here it will be still lesser than that because hemolysis is ongoing occurring.
Yes, sir.
So it requires a frequent blood transfusion.
Okay, sir.
You know these two words, hypertransfusion, supertransfusion?
Yes, sir. In hypertransfusion, our aim is to uh, have the hemoglobin of the child is more than 11, sir. In order to have the hypertransfusion, the hemolytic phases or Chickmunk phases will not be there, sir. Frontal bossing and malocclusion of the teeth will not be there, sir. And along with that, stunting and other delayed in the puberty will not be there, sir. And
So to prevent that disfigurement of the face, you maintain that hemoglobin. What should be the appropriate hemoglobin level you want to maintain?
sir, 9.5 to 10.5, sir.
Right.
Okay, so that hypertransfusion, supertransfusion, both are going to help to maintain. One is dysmorphic features won't come, and
Yes,
second is there will be no failure to thrive also. Child in the proper growth.
Yes, ma'am. Yes, ma'am.
And which are the iron chelators, and when you want to introduce that?
Ma'am, there is a desferoxime, desfera, Cirox, and desferriprone, ma'am. Desferriprone is intravascular. It is more helpful in intravascular, whereas desferrasirox is both intravascular as well as extravascular. And desferrioxime, ma'am, is IV and given IV or subcutaneously. So, in order, as desferrioxime is parenterally given, it is more effective, ma'am, but it is not so compliant, ma'am. So,
Compliant.
we go with the oral chelations, ma'am.
Decerprox.
Yes,
Oral
ma'am.
chelators, more
Yes, ma'am.
compliant and friendly to use. Okay.
Yes, ma'am.
So what levels of this you will be doing to know whether there is iron overload or not?
Ma'am, ferritin level is more than 1000 nanogram, ma'am.
When you start using, otherwise it may cause. If the iron overload occurs, what will happen?
Ma'am, it will causes cardiac and lung problems along with that endocrine disorders. Along with that, ma'am, it can cause auditory defects, ma'am, and vision defects, ma'am.
Very good. Which endocrine you want to test for?
Sir, it can cause hypothyroidism, pancreas, and hypogonadism, as well as hypopituitarism, adrenal insufficiency.
Very good. So all endocrine problems may occur from head to toe. Okay.
Yes, sir.
For liver iron accumulation, which is the gold standard test you want to do?
Sir, liver biopsy is the gold standard, but as it is invasive, sir, we go with the MRI, sir.
Okay. Very good. Very good.
Good. So, which is the other type of thalassemia?
Alpha thalassemia, ma'am.
Okay. When it can present, what are the different types in that?
Ma'am, usually it is in vitro. Getting a thalassemia trait and intermedia is okay, ma'am, but thalassemia major usually don't survive because of hydroxyphthalate, ma'am. Ma'am, your voice is not audible.
Yeah. Can you hear me now?
Yes, ma'am.
Okay. So with this, you are concluding that your case is
Thalassemia major, ma'am.
thalassemia major. So any other advanced treatments are available for this?
Yes, ma'am. We can go with hematopoietic stem cell transplantation, ma'am, for a curative,
Complete curative.
complete curate, sir.
Who will be the appropriate one for this, for stem cell transplant? How is the donor whom you will choose?
Ma'am, same. Ma'am, we go with an HLA testing, ma'am. If it is same, ma'am, or
If it was there, it would be easy.
yes,
But there are
ma'am.
no siblings in the family. Okay.
Family, ma'am. Yes, ma'am.
No siblings, only single child, na? As you told. Okay.
Yes, ma'am.
Anything else, sir? Ravikant sir, Rahul sir?
No. Almost he has covered everything.
Everything. Okay. So, Santosh, it was a good presentation. You were boldly presenting the case. So, this should be the method to present. For all the 42 participants, I will be telling you should tell all the words clearly and boldly. Don't hesitate to tell the words, otherwise, you will become more nervous. So, be confident in answering the things and never do or forget to write the headings of all the history. Never forget. Whole thing has come out very well, except for SMR, you had forgotten, especially
Yes,
from
ma'am.
the 9 years and onwards. You should
Yes,
tell
ma'am.
what is the SMR staging. Okay.
Okay,
So,
ma'am.
otherwise, it was a good presentation, and the differential diagnosis also you have covered very well.
Okay, ma'am. Thank you, ma'am.
Okay. Sir is here, Madhusudan sir.
Yeah, madam, I am very much there.
Sir. Yes,
Prasanna,
sir.
can you
Sir, yes.
stop sharing the slides? Yeah. That was a very nice jugalbandi, I call it as. Two examiners examining an undergraduate, and really very fortunate to have two knowledgeable pediatricians and guiding the students. And definitely these lectures will go a long way in guiding our undergraduates. Definitely our purpose of this IMA platform, I feel it is serving its purpose. Thank you, madam. Thank you, sir. Vikumar, sir.
Thank you.
And Subrata, madam, are you there?
Yes, sir. Sir,
Yes, madam.
it took me back to 15 years ago, my pediatric presentation, and
Yeah,
we're
definitely.
very fortunate to have madam who was very gentle, with gentle persuasion she has made you answer. You know, because she was telling, don't get tensed, be focused, think about this, and you have actually done well. I think, you know, being very communication is good, your slides are good, you have done this, has given you more confidence to present in your exam. So thank you, madam, sirs, three examiners, you getting here to present, even 50 people are there. I think it's a great opportunity for you.
Yeah, getting a certificate from psychiatrist is good. Santala, madam.
Yes.
Yes, sir. Yes.
Very
Ma'am,
gentle persuasion she made her answer. That was what struck me, you know, very nice.
interaction was really good. Santosh was very confidently answering the things. Though if you do, you are apt to make some mistakes during the presentation, Santosh. Don't get panicked. You are having so much again to tell ahead also. Some things we will miss because of the stress and all, but you should not get panicked. So this is for all the participants who are here. You don't get panicked. Feel free to answer. And something are mistaken or done wrong also, it's okay. But you should move ahead. Whole presentation will count and have the weightage. Important thing is your knowledge. Second is you have to get through the exam also, for which you should keep on answering till the end of the exam.
Okay, ma'am.
Correct.
Okay. So wish you all the best for the forthcoming exams.
Thank you, ma'am.
Any other suggestions, madam, for the whole fraternity of students?
Any
Yeah,
questions?
definitely. Yeah, any questions from the students?
Sir, there is no
Students,
question.
No
it's
questions.
open for a questionnaire now. Either all of you are intelligent, or all of you haven't understood.
Ma'am, I have a question on behalf of students. Like, for example, when she was asked about secondary sexual characters, so she was sincere and she said that I have not done it. I think, is it that is the right approach when some student has not done, right?
Because we don't have time, madam, during the exams,
Yes.
especially beat around the bush. They should be very frank that I haven't done. Next
Yes.
time I will the point that I will do it. That's all.
Correct. Okay.
Very way, I think, because we'll have again further examination points also. They will answer quickly and move ahead.
Fine.
So that will frank way of approach is very good.
Yes, good. Students?
Okay, sir. I thank everyone, and I especially thank Ravikant sir and Rahul sir who had interacted with the student to some extent. Thank you, Ravikant sir.
Thank you, madam. Thank you.
Thank you, madam.
Thank you, Rahul sir.
Thank you, madam.
Yes.
Very
Prasanna,
nice.
can we conclude?
Madhusudan,
Prasanna?
thank you for organizing all the things. You are very techno-friendly. You are organized very fast.
Thank you, madam. All those brochures are designed by me.
Oh, yeah, I know, sir. You are very quick. I have seen you in the Medicon.
Thank you. Thank you, madam.
He is there everywhere in IMA Karnataka. Sir is there in all committees. Though he doesn't want his name to be there.
ಹಂಗೇನಿಲ್ಲ ಮೇಡಮ್.
ಇಲ್ಲ ಎಲ್ಲಿ ಹೆಸರು ಇರಲ್ಲ, ನೀವು ಎಲ್ಲಾ ಕಮಿಟಿ ಮೀಟಿಂಗ್ ಅಲ್ಲೂ ಇರ್ತೀರಾ. ಯು ಆರ್ ದೇರ್ ಇನ್ ಎವ್ರಿಥಿಂಗ್. ಯು ಆರ್ ವರ್ಕಿಂಗ್ ಫಾರ್ ಎವ್ರಿಥಿಂಗ್.
IMA is my somewhat hobby working.
Correct.
I want juniors to come. So many juniors are there. We want to build a second line, third line leadership in for the fraternity, medical fraternity. Somehow we are missing it. Probably in the coming days we will have more juniors, youngsters to come to the forefront. We will take it forward. Definitely, they will be impressed by all our involvements. ನೀವು madam, it's a very happy thing for IMA that you are showing your strengths to IMA, because we may not be in an organizing team. We are in the organizing team. moving with everyone. Even 21 subcommittees are there. All the subcommittees I am moving with them. It is a thing that is happening, and we are organizing things for all other subcommittees also. It was nice that MSN and academic committees are doing very well. This is what I was telling the Srinivas, our president.
No, sir. Thanks to Srinivas sir and all the IMA team for choosing me as a co-chairman, or you have given some chair. That is very important now to interact
Have
with
some
you.
plans, madam. Have some plans for academic activities of your own. We can definitely take forward to students. You can have it. Andre,
Yes,
your
yes.
own idea, ಹೊಸ ಐಡಿಯಾಗಳು ಏನಾದ್ರು ಇದ್ರೆ, we will have a
Yes, sir.
space to implement them. Not only the case
Definitely.
presentations, definitely you can call for your subcommittee meeting, madam. ಒಂದು closed 6 ಜನ ಇರ್ತಾರೆ. I'll talk to all of them. You can have a
Okay, sir.
meeting, and we can take their ideas into action in the coming days.
Okay, sir.
Sir. Prasanna?
Live streaming.
Sir, yes.
Can conclude.
Yeah, you can conclude.
As the section has come to an end, I would like to thank Dr. Shantala ma'am, Dr. Karunakar sir, Dr. Subrata ma'am, Dr. Ravikant sir, and Dr. Rahul sir. Thank you.
Yeah.
Thank you, sir.
We thank
Thank-
all of you on behalf of
Okay.
IMA Karnataka State Branch. All the best for all your exams. Thank you very much. Thank you, everyone.
Thank you, sir.
Thank
Bye, madam.
Bye.
Santosh, you did very good. Excellent
Thank you.
presentations. And
Thank you, sir.
slides presentations, everything was fine. Carry on. Have a good future.
Thank you, sir.
Bye. God bless
Thank
you. Convey our regards to your Narayan Murthy sir.
Okay, sir.
Narayan Swami, your principal.
Yes, sir.
Probably he would have been glad to join this. I just forgot to convey the message to him to join.
Yes, sir.
Oh.
Yeah, all the best.
Thank you,
Bye.
sir.
You can
Thank
leave.
you.
Thank you,
Thank you.
ma'am.
Bye.
Thank you.
Good night.
Wait.